Welcome back, fellow mitochondriacs, to another episode of Cancer is a Mitochondrial Metabolic Disease. What if one of the biggest problems in cancer isn't just the tumor itself, but the lack of oxygen inside that tumor? Many people know that oxygen is fundamental to how our cells produce energy, yet many tumors are profoundly oxygen deprived or hypoxic. And yet the lack of oxygen may be one of the key reasons cancer thrives and behaves in the way that it does, and why many conventional treatments fail. So what happens when we change that? In this video, we're going to introduce the basics of oxygen therapy, including normobaric and hyperbaric approaches, and how increasing oxygen levels may influence tumor biology and treatment response. So without further ado, let's get into it. So this is a topic that I have been wanting to cover for quite some time, but I just wanted to give us the background information that we needed for this to make sense. In particular, I wanted to establish that there is a problem with low oxygen in the tumor and how we might then go about it with some different modalities that we're going to cover in the next several videos. So I'm going to be using this paper to help us get through this video. And this paper was titled Role of Hyperoxic Treatment in Cancer, and it was published in May of 2020. And it says here in the abstract, tumor hypoxia promotes cancer aggressiveness and is strongly associated with poor prognosis across multiple tumor types. The hypoxic microenvironments inside tumors also limit the effectiveness of radiotherapy, chemotherapy, and immunotherapy. Several approaches to eliminate hypoxic state in tumors have been proposed to delay cancer progression and improve therapeutic efficacies. This review will summarize current knowledge on hyperoxia used alone or in combination with other therapeutic modalities in cancer treatment. Molecular mechanisms and undesired side effects of hyperoxia will also be discussed. So in the first part of this paper, it's going to introduce just hyperoxia, or higher amounts of oxygen that we get ambiently in the environment. So in this section, it says, many reports suggest various beneficial effects of hyperoxia on hypoxic tumors. Hyperoxic breathing of 60% oxygen recovers oxygen homeostasis and tumor microenvironment hypoxia to normoxia, inhibits survival and proliferation, stemness, and immune escape of cancer cells, resensitizes chemo resistance, leading to tumor regression. And it gives all the references there. We also reported anti-cancer effects of hyperoxia alone or in combination with a chemotherapeutic drug, carboplatin, on mouse lung cancer. Normobaric hyperoxia significantly induced oxidative stress and apoptosis in tumor tissue and reduces tumor mass and migration invasion. Differential response of cancer and normal cells to hyperoxia has also provided a treatment rationale of hyperoxia in cancer treatment. Basal antioxidant defense levels are aberrant in tumor cells. Thus, an increased oxidative stress has been observed. Since the superoxide dismutase activity of most tumors are lower than normal tissues, tumor cells show higher susceptibility to increased ROS activity induced by hyperoxia. Synthesis of glutathione, GSH, and antioxidant preventing ROS-induced damage increases proportionally to ambient oxygen tension, but not in cancer cells. Inconsistent with these findings, we demonstrated that normobaric oxygen NBO showed antitumor activity of lung tumor cells, but not in normal lung cells. In addition, hyperoxia is angiogenic in normal tissues, but anti-angiogenic in tumor tissues. Anti-cancer mechanisms of hyperoxia can also be inferred indirectly from clinical and experimental findings. Roles of HIF-1 alpha in hypoxia-mediated cancer development are widely acknowledged, and hyperoxic treatment has long been used to cure clinical disorders such as hypoxia or ischemic diseases by increasing oxygen delivery to oxygen-deficient tissues. We can also take a hint from well-known mechanisms for the induction and regulation of HIF-1 alpha. HIF-1 alpha protein is subject to degradation through an oxygen-dependent ubiquination, and hypoxia-induced HIF-1 alpha protein is rapidly decayed within 5 minutes upon exposure to normoxia, 20% oxygen. In addition, transcriptional activity of HIF-1 alpha is enhanced by hypoxia-induced ROS and inhibited by oxygen in non-hypoxic cells. Taking these findings together, it seems rational, it seems reasonable that therapeutic effects of hyperoxia on hypoxic tumor are mediated through not direct regulation of HIF-1 alpha, but primarily the reversal of hypoxia and the attenuation of the hypoxia factor immediate effects. However, despite accumulating evidence supporting this idea, many reports also indicate HIF-1 alpha independent effects of hyperoxia on tumor. For example, both normoxia and hyperoxia induces higher levels of HIF-1 alpha than hypoxia in tumors, but tumors grow faster in hypoxic groups, suggesting that signaling pathway other than HIF-1 alpha driven response may be playing an important role for in vivo cancer cell proliferation. Recent reports also showed that HIF-1 alpha levels in tumor cells was significantly downregulated in hyperoxia, 60% FiO2, compared to normoxia, 20% oxygen, indicating that alternative mechanisms other than simple reversal of tumor hypoxia to normoxia underlie antitumor effects of hyperoxia. Coincidentally, Rocco et al. Suggested that relative changes in oxygen availability rather than steady state hypoxia or hyperoxia conditions play an important role in the HIF transcriptional effects. In addition, hyperoxia activates HIF-1 alpha overexpression through the activation of the SERC oncogene and also inhibits the stability of HIF-1 by reducing ROS formation. Despite numerous attempts, mechanisms underlying hyperoxia-mediated anti-cancer activity remains to be elucidated. Hyperbaric oxygen therapy. HBO, hyperbaric oxygen treatment, is breathing 100% oxygen at higher atmospheric pressure, usually between 1.5 and 3 atmosphere, which enables the lungs to receive more oxygen up to 3 times under normal pressure, resulting in immediate saturation of plasma with oxygen. In normal subjects, compared to normobaric air, hyperbaric oxygen at 3 atmosphere increased both arterial from 100 to 2000 millimeters of mercury and tissue from 55 to 500 millimeters of mercury oxygen tensions. Similarly, the PO2 level was significantly increased in tumor tissues by hyperbaric oxygen exposure, demonstrating 3 to 4 times greater hyperoxygenation effect in tumor tissue compared to that of normobaric oxygen. Therefore, hyperbaric oxygen rather than normobaric oxygen has been preferentially used to eliminate poorly oxygenated regions of tumor, which play a major role in tumor development and resistance to other therapeutic modalities. In addition, hyperbaric oxygen therapy is considered safe and well tolerated, and side effects are rare. Although several studies showed the favorable outcomes of hyperbaric oxygen by itself in cancer treatment, hyperbaric oxygen alone gives a limited curative effects, and it even enhances tumor growth. That I would actually be very highly skeptical of, knowing what we know about cancer. Accordingly, hyperbaric oxygen is preferentially used as an adjuvant treatment for enhancing tumor sensitivity and decreasing complications of other therapies. So that's the hyperbaric oxygen blurb or section in this paper. Now let's talk about normobaric oxygen. Normobaric oxygen therapy, NBO therapy, is a routine adjuvant oxygenation intervention supplied either by nasal cannula or face mask under ambient pressure. For cancer treatment, NBO is an attractive alternative to HBO due to its ease of administration and lower complications in actual clinical practice. However, when compared to HBO, effects of NBO on arterial and tissue oxygenation is much weaker. Arterial PO2 in the aorta has increased only 4-fold after exposure to normobaric oxygen, 345 millimeters of mercury versus 84.1. In animal studies, most of the tumors were nearly anoxic, less than 1 millimeters of mercury, but normobaric oxygen immediately increased the PO2 to above greater than 25 millimeters of mercury and remained elevated during gas exposure. Accordingly, normobaric oxygen treatment significantly retarded tumor growth. We also previously showed that normobaric oxygen inhibits lung cancer in vivo and in vitro through reactive oxygen species generation and apoptosis. So just a couple of things. We're going to look at specifically the amount of oxygen delivery potential by both hyperbaric and normobaric oxygen in the next slide. But I wanted to highlight this. They're saying that in animal studies, most of the tumors were nearly anoxic, less than 1 millimeter of mercury. What I've seen is that's the case in the most hypoxic regions, not the actual entire tumor itself. The actual average tumor millimeters of mercury for most tumors is about 10. Some are less, some are slightly more. And then the hypoxic regions can be nearly 1 millimeter of mercury or less than that. And what it's saying here is that when you apply normobaric oxygen, it immediately increased the tumor oxygen status to greater than 25 millimeters of mercury. If you remember from a fairly recent video I did on hypoxia and cancer and how hypoxia leads to radiation therapy resistance, about 12 millimeters of mercury is the cutoff for radiation resistance. So if you can go from very severely hypoxic or anoxic, nearly anoxic, like it says here, at less than 1 millimeters of mercury, and immediately raise it to 25 millimeters of mercury or greater, that is going to make that radiation treatment much more effective. I'm not saying that you should do radiation or not do radiation. I'm just saying that that is the facts of how it's dependent on oxygen to be functional. So this is a table that I built using gas laws, and I want to help illustrate the difference between normobaric oxygen and hyperbaric oxygen. And I want to look at some examples of what this could look like and why it's important. So in this table to the left, we're going to see FiO2, and that stands for fraction of inspired oxygen. So it's pretty much the percent oxygen that you're breathing in. And all of us at room air are breathing in 21% oxygen. And then we can add from there. And in order to achieve this level of oxygen, you'll need this device or this device or this device, right? And there's two columns that I want to show off next. And that is going to be estimated hemoglobin saturation, which is your SpO2 or your fraction of hemoglobin. And that is going to be what you would look at if you were doing a pulse oximeter. And most people know that unless you have a illness of some sort with your lungs, we're going to be satting between 97 and about 100%, depending on how deep we breathe and so on and so forth. So this is already at ambient pressure and percent oxygen, pretty much already maxed out. And so we're not really concerned about getting to 100% here. That's not going to be moving the needle for us. What is going to be moving the needle for us is the amount of dissolved oxygen in plasma. And that's here measured in milliliters of oxygen per deciliter of blood. So we see here that at 21% oxygen or room air, under normal pressure, we're dissolving somewhere between 0.24 and 0.31 mLs per deciliter of blood. As we increase the amount of oxygen delivered or inspired, you can see how that ramps up pretty quickly. And by the time we get to 90 or 100% oxygen, we are darn near 10x, 8 to 10x where you would be at if you were breathing in normal air. So this is what really we're looking for in both hyperbaric and normobaric oxygen, because if you remember back from the last video, the oxygen gradient is higher when you're next to a blood vessel, and the further you get away from that blood vessel, the lower the oxygen becomes. So if a tumor is next to a big blood vessel, then the outside of the tumor will be more normoxic. And then as we get deeper into the tumor is where you have the hypoxic core or even necrotic cells where it becomes very hypoxic or anoxic. And that is because, number one, some of the oxygen is being taken up by other cells. And then the other thing is that these blood vessels that go into the tumor are diseased, and hemoglobin is inside the red blood cell, and that requires a certain size. So if these blood vessels are small and disorganized, then RBCs cannot actually get into there. And so therefore, you're only using what you can actually deliver. And so if you have very low amounts of oxygen in the plasma normally, then what's really going to move the needle for us is not by supersaturating hemoglobin, we're already maxed out. We're going to be supersaturating the plasma or the water part of the blood that is going to move the needle for us at oxygenating that tumor. And so you see here that as we increase oxygen amount percent, that amount of plasma oxygen increases. Now let's take a look over to the right side of the slide to this table. And this is about hyperbaric oxygen. So you see here, again, here's 21% oxygen or room air and at normal pressure. I've given multiple different situations in this slide that makes this a little more interesting. So for example, you may have a soft shell chamber, which goes up to 1.4 atmosphere. But because that oxygen that you put in your chamber is mixed with air at 21%, even though you have a 10 liters per minute concentrator trying to fill it up, the actual like percent oxygen in that soft shell chamber is going to be somewhere between 21 and maybe as high as like 30% oxygen. It's not 100%. So you see here that at 1.4 atmosphere at roughly 21% oxygen, you're only dissolving 0.5 mLs of oxygen per deciliter of blood. Whereas if we just put a mask on you, 5 liters per minute of nasal cannula or a simple mask on you, 40% oxygen, you're actually dissolving more oxygen in plasma with that simple setup compared to hyperbarics. Now, if you start moving into a hyperbaric chamber that is a hard shell chamber and it has this BIBS mask where it can deliver 95% oxygen, Then you start adding pressure, you get a return on your investment. So for example, you see here's 95% oxygen at 1.4 ATA. So because the oxygen is the same or similar to 90 or 100% oxygen, but we're taking that same percent oxygen and we're adding pressure to it, that's your bang for the buck, right? So here's the max you'd get, like 2 to 2.17 mLs of oxygen per deciliter, right? At 90 or 100% oxygen under normal pressure, right? When you add pressure to that at 1.4, you get 2.84. Or if you go up to 2, you get 4.18, which is double. And then if you go even higher than that, 2.5 atmosphere in a medical grade HBOT at 100% oxygen or near 100% oxygen, then you're at 5.3. So this is where you see the bigger bang for the buck, is when you're in a hard shell chamber, you have 100% oxygen or near 100% oxygen, and you're adding pressure. This was very eye-opening for me, because you would think that if I have a 2 atmosphere pressure, a reinforced soft chamber, and you're breathing in, basically air, you would be getting a big bang for your buck. But actually, you see the FiO2 makes a bigger difference, or the percent oxygen makes a bigger difference to a point. And then once you max out that, then pressure adds. But if you just do 21% oxygen, even at 2 atmosphere, you're basically competing with 50% or 40% oxygen at normal pressures. So I like this and I don't like this. The reason why I like it is because this is much more accessible for people as a modality, right? Getting a 5 liter per minute or a 10 liter per minute concentrator, although not a cheap thrill, is nothing compared to a soft shell HBOT chamber, right? But I also feel for people who bought an HBOT chamber and they are only getting 21% or 30% oxygen. You're not really doing yourself anything better probably than what you would be getting at 50% oxygen or 40% oxygen through one of these devices. If you have the ability to afford either going to a hard shell chamber in your local area or affording a hard shell chamber, then I do think that you're getting a bigger bang for your buck for those situations, but that's not a lot of people who can do that. So there are ways that we can potentially overcome the differences here. Let's say hypothetically, we're going apples to apples, 90% or 95% oxygen in normal pressure situation, or 95% oxygen at 2 ATA. This clearly beats it, right? 4.18 versus 1.8 to 2, right? And that's true if you're not moving. But if you start to increase your heart rate for some reason, then the amount of oxygen delivered to that tissue, even though it's half the amount, then per unit time, you may be able to compete with this. Just a little bit of a preview to things to come. So as I said here in the last part of this portion of the paper, hyperoxic therapy in cancer oxygen therapy is a type of treatment to enhance the amount of dissolved oxygen in plasma by breathing in supplemental oxygen, therefore increasing oxygen delivery to body tissues. For hyperoxygenation, 100% oxygen is administered to a patient either in ambient pressure, normobaric oxygen, MBO, or under hyperbaric conditions, usually under a pressurized chamber, hyperbaric oxygen, HBO or HBOT. Oxygen therapy has long been regarded as integral to the management of various medical conditions for centuries. For cancer treatment, there is still no evidence that is effective for treating cancer. I would beg to differ. There's actually literature that shows efficacy, there's a ton of evidence for preclinical models, and there's actually evidence in patients as well if you dig into the literature. So to say there's no evidence is actually not true. However, despite ongoing controversy, interest in applying hyperoxic therapy as adjuvant for cancer treatment is rapidly growing. For example, in PubMed search concerning oxygen therapy in cancer, since the first article in 1951, there have been more than 20,000 articles found. A brief summary of hyperoxic therapies on cancer is listed in Table 1. In addition to oxygen breathing, although relatively uncommon, other forms of oxygen therapy, such as oxygen-containing substances, ozone, hydrogen peroxide, and prodrugs that are activated only in hypoxic tumor environments, also been tried for cancer therapies. So I'm going to stop here. This is meant to be a primer, a basic overview of hyperoxia, or increasing the percent of oxygen delivered to a person who's trying to use it as an adjunctive for cancer. And I think that this is going to be an exciting next couple of videos, because we're going to go over normobaric oxygen in greater detail. We're going to go over carbogen in greater detail. We're going to go over EWOT, or exercise with oxygen, in greater detail. And then we're going to hit hyperbarics in greater detail. And we're going to really hash out what is the proposed solutions to this tumor hypoxia problem. If you like videos like this, please like, share, and subscribe. And until next time.